Good afternoon, ladies and gentlemen. I'm Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council. We want to thank you for being here today. As you know, this is another one of our educational webinars, and it's hosted in coordination with BKD, CPAs, and advisors, and they're an associate member of the council. And really, BKD doesn't really need an introduction. I think most people know that they do quite a bit of healthcare work, especially throughout the nation, but here in the state of Texas. In fact, I think all of our public hospitals are audited by BKD here in the state of Texas. And today's topic, where hospitals stand, related to RAC Audits, 340B, things related to the Surprise Act. It is so important that we understand this. But their expertise goes well beyond the standard accounting services that I mentioned earlier. They include healthcare advisory services, risk management, technology, wealth management, and forensic and valuation services. And they represent a wide range of industry and are even part of an alliance of firms that reach across the globe. We've got three experts today, and we're delighted to welcome Dan Clark, who's Managing Director, Paula Archer, who's Director of Healthcare Performance Advisory, and Brian Bell, Managing Director, Healthcare Performance Advisory, and they're each going to serve as speakers on these important topics. And we're going to discuss, as I mentioned earlier, No Surprises Act, RAC Audits, 340B. And we all know these are crucial issues that our hospitals are all facing today. So without further ado, I'm going to turn this over to first Dan Clark. Welcome, Dan.
Thank you so much, Mr. Love, and thank you, Dallas-Fort Worth Hospital Council. It's really an honor and a privilege to be part of your program today. And let me just say, as we kick this off, just our heartfelt thoughts go out to those that were impacted by the storm and the hail. Saw that this morning when I got up and just kind of said, wow. So certainly our thoughts are with those that were damaged there. As Mr. Love mentioned, my name is Dan Clark. I'm a managing director, and I'm with my colleagues Brian and Paula today. Paula is out of the Dallas office. We are part of a national performance advisory practice that supports really the entire BKD as a firm, but certainly supporting Chris Clark, our regional partner there out of the Dallas office and that office. So please do not hesitate to reach out to any of us if there are any questions that come up or arise. We are happy to help you in any way. As we get into the actual presentation today, we kind of thought it might be, it might keep the energy a little higher if we could present maybe three different topics as opposed to just one long 40-minute topic. So we decided to really kind of roll out some of those things that are, as Mr. Love mentioned, impactful today, and those things that we're going to present. Brian's going to touch on 340B, drug pricing. Paul's going to touch on RAC, and I'm going to touch on the No Surprises Act. So without further ado, we can get started into the program. I'm going to turn it over to Brian and talk about 340B. Brian?
Sounds good, and thanks, Dan, and good afternoon, everyone. Definitely appreciate the opportunity to spend some time with you to discuss the 340B program today. I spend the majority of my time assisting clients maintain compliance and optimizing their 340B program, as well as pharmacy. And as many of you on the phone know, 2020 and 2021 have been trying years for 340B covered entities across the country. 340B is a critical program for covered entities across the country. And really without 340B, many providers would struggle to keep their doors open and provide the necessary services to their communities. 340B also provides significant opportunities for covered entities to grow their services for their communities and really expand their reach in their communities. And right now, the 340B program, it's under constant scrutiny in DC as well as by the manufacturers. And now it's more important than ever for covered entities to have a strong focus on advocacy. So I'm gonna start off talking through some 340B strategy ideas that really have hit home for many organizations around the country during the past few years, especially. So we know that your 340B strategy really determine your savings as well as kind of how you utilize those savings while maintaining compliance. And really, your strategy is more important now than it ever has been. And as I get into some of the manufacturer updates, I think that'll resonate pretty well with the group. And really, as we move forward, we really need to focus on potential legislative changes, as well as our strategy around how to handle manufacturers and other requests, and how do we expand our program. So first off, the conversion of freestanding physician offices to provider-based clinics. So many covered entities are taking advantage of the new HRSA interpretation stating that hospitals no longer have to wait until provider-based clinics are on the most recently filed cost report to participate in 340B. Clients from coast to coast are converting these freestanding physician offices to provider-based clinics. And really, it's not a focus on reimbursement, but it's the focus on expanding our 340B savings. And with this new interpretation, oftentimes as we've worked through these conversions, organizations may have had to wait 20, 22 months, and now that wait is over. During the course of COVID, many covered entities are also taking a deep dive into their contract pharmacy arrangements and really trying to determine if they're contracted with the right pharmacies. So this includes adding and potentially terminating old arrangements. So we know with some of those older arrangements, as the dispensing fees and contract terms change, sometimes they're just not as profitable as they historically were. Contract pharmacy savings are significant, and really we should monitor these on a regular basis and make sure that we're constantly looking at our capture rate to make sure that we're maximizing our savings with our existing clinics, as well as those clinics that may need to be converted to provider-based clinics in the future. The next item is around entity-owned retail pharmacies, and this is definitely the hot topic right now, and it's something I'm spending a lot of time talking to clients with. And really, organizations are just looking for opportunities to enhance or expand their entity-owned retail pharmacy. They're looking to buy local pharmacies as well as starting these pharmacies from the ground up. So it does a few things. So this alleviates the administrative burden and fees, as well as avoid some of the manufacturer barriers that are blocking 340B savings. It also allows organizations to help their patients with medication adherence and copay assistance. And really, as we think about these entity-owned pharmacies, we can also expand our refill rate, because we're seeing these patients on a regular basis. And one of the ways that we can expand that refill capture rate even more is through offering mail delivery services, and really something that patients around the country are growing to expect are, they're expecting to have more and more of those convenience options. And then lastly, formulary and prescribing strategy. And these are really top of mind for 340B covered entities. And this can be a way to combat some of the manufacturer barriers that I'm going to discuss. So many organizations are thinking through this, and if a manufacturer is going to not meet their statutory obligation to provide 340B pricing, then covered entities are going to try to avoid them when patient care is not impacted. This will be a hot topic as well at the state level, as the attorney generals step up to assist covered entities in these efforts against the manufacturers. Next slide, please. Yeah. So 340B and telehealth. The COVID-19 pandemic, as everyone knows, has really forced providers to to expand their telehealth and or for some really get their telehealth off the ground. And from a 340B perspective, it's important to know that these telehealth visits can be 340B eligible in most cases, as long as the definition of patients met. And really, it's important to update your policies and procedures so that we know that we're meeting the compliance requirements. It's also important from an IT perspective to make sure that those visits are being qualified with your TPAs. And really, when we think about these telehealth visits, it provides covered entities with the opportunity to expand their 340B program reach. So historically, we may have focused more on those contract pharmacy arrangements that are closer to our clinics, but as we have these telehealth visits and we expand that reach, we may have the need to expand our contract pharmacy arrangements to really reach out to where our patients are living and where they're being seen during these telehealth visits in their homes. So the manufacturer barriers, and I know that many on the phone have probably heard about these barriers and some of the things that the manufacturers are doing. And really what we're seeing is there's a number of manufacturers that are starting to challenge the 340B program at the contract pharmacy level. And for some covered entities and some of our clients, as we've talked through this, we're seeing about a 15 to 25% reduction in savings. And so I think that's why it's more and more important to kind of have those advocacy efforts as we think through this. So high level summary, so AstraZeneca, Eli Lilly, Novo Nordisk, and United have limited 340B pricing at contract pharmacies in late 2020 and in early 2021. And then Sanofi, Novartis, and Merck have asked for all claims to be submitted to a software called 340B ESP in order to obtain 340B pricing at the contract pharmacy level. Can you move to the next slide, please? And really, as we look at the updates for these additional manufacturers, so Novartis has really backed off limiting 340B pricing if claims aren't submitted. They have excluded contract pharmacies that are not within 40 miles of the hospital. One thing to note with this limitation of the 40-mile distance is there are exceptions that are available. These exceptions have to be requested through Novartis on a special form. And I think most often for those contract arrangements that are 40 miles away from our hospital, those are our specialty pharmacy arrangements. So we really want to focus in on those so that we don't lose those significant savings associated with our specialty pharmacies. Merck, they are requiring the submission of data for all 340B claims to 340B ESP. And then when we think about all claims, this presents a pretty big issue for as manufacturers try to expand the duplicate discount definition from Medicaid to all payers. So there's this need to worry about HIPAA when submitting these claims to a company that they don't have a relationship. And really, we just need to think about this before we submit anything, because if entities start to submit data to this program, then that's going to kind of reduce our fight as we fight against some of these requests. And right now, about 95% of the covered entities across the country are not responding to these requests. Next slide, please. A little bit of background, I'm not going to spend a lot of time on 340B ESP and Calderas, but when we think about these two companies, these are private companies that are really trying to change the landscape of 340B by partnering with manufacturers. And 340B ESP is assisting manufacturers with collecting the claims data, and really Calderas is trying to change the program from a savings program to a rebate program. So I think it's important as we receive these requests from these two companies that they don't have regulatory power, even though their emails and some of their calls feel like it. And once again, it's important to think about the impact around HIPAA, discriminatory pricing, as well as what are they going to do with all this data. So the response from DC and the industry has been pretty amazing. So the new HHS secretary, he is a huge supporter of 340B. As the previous Attorney General from California, he believes that the enforcement of 340B discounts should occur. He has stated publicly that manufacturers are violating their obligations and plans on reining in pharma. He'll also work closely with the states to rein in pharma at the state level, which will be very, very important. Covered entities also have the support of Congress. I always say that this is kind of the one thing that we're seeing bipartisan support for, other than the opioid crisis. And really, it's just been amazing to watch the DC and other organizations work together to fight these barriers. And then, as many of you know, there's a number of lawsuits that are trying to fight and block these manufacturer barriers. And based on some of my conversations with legal entities around the country, I'm not sure the lawsuits are necessarily going to be the fight. I think it's going to be on behalf of the attorney generals and what the secretary is able to do in order to provide HRSA and HHS the regulatory power that they need in 2021 and beyond. So Pbm Changes, Express Scripts, Humana, and OptumRx, they've all updated their 340B manuals for 2021 and require some changes around how claims are to be billed and the requirement of new submission criteria of the Code 20. This change is going to require some additional resources to process claims, and really when and what is the timing to include that criteria code. So I think oftentimes those new manuals come out and entities don't spend a lot of time with it, but I think this kind of proves that we really need to spend a lot of time on an annual basis making sure that we're understanding these changes. And then I'm gonna wrap up talking about Medicare, your disproportionate share percentage. And I think this is something that on a daily basis between the 340B team and our regulatory team that we're receiving questions around this, and is there going to be a DSH waiver? So for many organizations, we know the impact of COVID-19 has been negative in relation to their DSH percentage, which is required to be maintained at 11.75% for DSH, and then 8% for sole community hospitals and rural referral centers. And then this impact could also have a negative impact on your SSI percentage. There have been 2 bills introduced, but neither moved forward. The goal was to maintain 340B eligibility for a period of time, even if the DSH percentage falls below. There's a new bill that's also trying to accomplish this. Most recently, AHA has sent a letter to the new HHS secretary asking for a waiver. So there's a lot of support around this, and definitely under the microscope for many entities around the country, and we'll continue to keep a close eye on this and provide updates as we receive those. So I definitely appreciate everyone's time. I'm gonna hand it over to Paula now, and she's gonna provide an update on RAC activity.
Thank you, Brian. You know, this is a RAC update, but I really wanted to specify it's an activity update. So we're just going to talk through about what we are seeing in the industry currently, as well as other governmental agencies that are ramping up their audit activities. So that's what we're going to be discussing today, or what I'm going to notify Texas hospitals of. And this is a very familiar map, and it's really interesting because there's been changes to this map just recently, but I have not noticed or recognized a most current one. But the focus that I want you to see today, and what we want to talk about specifically, is that Region 4, and that is HMS, Federal Solutions. You'll notice they're up there in the northwest part of the country and western part of the states, and then they dribble over just a little bit on the East Coast with Pennsylvania, New Jersey, and Delaware. I want to really focus on them in the next slide presentations, and we do know nothing has changed with Texas, right? It's still Cotivity is the current RAC in Texas, but I think that you're going to see, and we're going to see all of these things come together, and I hope that what I outlined to you today will help recognize some possibilities for items that we need to really be paying a lot of close attention to. So we're going to talk about Region 4 again. This is HMS to start with. And this is effective August the 3rd of 2020. CMS resumed its Medicare fee-for-service audit activities. And what they're doing is looking at encounters prior to March the 1st. So they're not focusing anything on COVID-19 coding at this time, but we'll talk about that later in this presentation. But what I want you to know about HMS, they're a very aggressive RAC in the country right now with a lot of activity. And they have partnered with Max, Noridian, and Novitas for a lot of web-based training. And this training, I tried to get on it, but it's already occurred. So we can't even, I don't think it's even recorded. But I would go and look to see if you might be able to find some information on Novitas. But what I'm really concerned about here, and even for Texas, because in Texas, Medicaid reimburses APR DRGs. There are children's hospitals in this Region 4 that are currently being audited for clinical validation of their DRGs, as well as short stay reviews. And what's really interesting about the short stay reviews, a lot of the claims that they have selected as adverse actions have been for clinical validation of the DRG, but when they get into the record, it becomes a medical necessity issue. So while the intent originally was to look at possibly a coding downgrade of a DRG, it became more of a medical necessity. So therefore, what these hospitals are seeing is that it could be a 2 to 3 day stay that is now getting denied for medical necessity. So the caveat there may indicate that some of these inpatient encounters were possibly coded incorrectly that triggered this type of review. And so really, APR DRG clinical validation and short stay audits, as I said, is a focus of this Region 4 RAC, HMS. We'll just go to the next slide, please, Dan. Thank you. And this is really interesting. Cotivity, our Texas RAC, it has approved issues noted on its website as of just a few days ago, weeks ago, April 19th of 2021. And lo and behold, they are still looking at inpatient hospital MSDRG coding validation. And here's another one that we see that pops up quite often is critical care and billing excessive units. And when I state that, critical care is based on time reporting, so it's very important for the physician to document that time and that the coding and the billing, the charge capture of that time, is reported appropriately in the units for the time-based codes. And then this is nothing really new, but it's coming up more and more, and I think it will be a continued focus, is the inpatient psychiatric facility, IPF-PPS, medical necessity and documentation requirements. And what I mean by that is mainly, I would say, documentation requirements. The MACs are continually looking at the certifications, the recertifications, as well as the timing of those documents. And also outpatient APC coding validation. And you know, what's scary about this one is it can be so broad. It can be basically about even the CAPCs, the comprehensive APCs, in which a lot of the services should be rolled up into one procedural payment. And also what can evolve out of this is looking for documentation. And when I say that, I mean also for the infusions and the injections that might be provided in the outpatient setting, whether that's in the emergency room or else also in observation. You can move it on, Dan. Thank you. So I also wanted to talk about the governmental agencies, and this is always a fun topic. And you know, not to our dismay, but things that we need to know about. Officer of Inspector General, the OIG, recently published their concerns about high severity MSDRGs with short lengths of stays. And I put the website there, and you can visit that at your convenience. But basically what they're saying is that there are a lot of DRGs with complications and comorbidities that would anticipate a geometric length of stay of maybe 4 or 5 days, but they actually are maybe 2 days. So that's what they're concerned about. And so what they've also stated, the OIG, is that there's some possible maybe problems with the hospital CDI program that may be too aggressive. So also, we just know that this is something that is going to be looked at, and we'll talk about that again, and we can see how all of this flows into different governmental agencies and what they're looking at. If one is not looking at it, then someone else is typically. And also the OIG has already specified that their COVID coding compliance, they're really interested in the 20% add-on reimbursement that hospitals have been getting for the diagnosis of COVID. So right now, you know, they're not looking at it. The RACs are not looking at that right now because they're looking at things issues prior to March the 1st of 2020. But the OIG has stated right here that this is going to be on their radar for 2021 and 2022. Also, the Medicare telehealth services during the COVID-19 pandemic is going to be a focus of the OIG. So I need to make sure, you know, that those telehealth visits are face-to-face, that they're coded appropriately with the correct modifiers and the correct procedural codes. And so the OIG has also said that they tend to expand the scope of audits, both pre-pandemic and post. So I think a few recommendations is to, as we've done in the past and will continue to do, is data mining and internal auditing of these services, and check the peppers for possible outliers. What we find many times is that these reports go to someone that's really not checking them routinely as they should be checked, but these are wonderful resources to show hospitals of possible outliers where they need to probably focus in on some compliance areas. And for those COVID encounters, be sure that you have a COVID test that is positive and that your coding department is coding those correctly. There is a new contractor, and lo and behold, we're going to talk about what their focus is. And I'm not even sure how to pronounce this. I think it's Levanta, but they recently were named as a contractor for National Medicare Claims Review. And this is a nationwide basis in every jurisdiction. And so they are a QIO, and their focus is 2 items. Here we go, 2 items. The higher weighted DRGs, the one we just discussed about the OIG, and what they're calling those are HWDRGs, higher weighted. Thought that was very interesting. And then also the short stay reviews, those that are less than 2 midnights is what they're specifying on their website. So the recommendation here is to, you know, assess the CDI program and compliance of it. CDI programs are wonderful, but also balance that with compliance to make sure that there's clinical validation and compliance with queries that are going back to those physicians. Also, assess the use of a current spend code 72 for the 1-day stays in your organization. This is a billing code that can also tell Medicare that for 24 hours or more, that your patient received care within either the emergency room or an outpatient procedure or in outpatient observation services. So that really identifies those types of cases for you and really helps to support the one-day stays that your organization might have. So let's go to the next slide. And we're going to go right into Dan, who now is going to give us some really good updates about the upcoming No Surprises Act.
Thank you, Paula.
Thank you.
Thank you. Let's get into the No Surprises Act. This is certainly an interesting one. As many of you are aware, the Consolidated Appropriations Act was signed late December by President Trump. This is a massive act, thousands of pages, and if you look way down towards the bottom in the table of contents, you'll find the healthcare provisions. The No Surprises Act, the section on transparency, and a couple of other sections do point out Division CC under health extenders. There's some interesting things there around distribution of additional residency spots and improving rural health clinic status by essentially doubling the cap over the next 10 years, so increasing those payments for rural health clinics. I've identified a really nice summary of the entire healthcare provision. If you'd like, shoot me an email. I'm happy to send that along to you. That kind of outlines in much more brevity than the actual act, which is difficult to read, all of these sections. So, please feel free to reach out. So in today's discussion, do not intend to go through the entire section by section provision of the No Surprises Act. Really just want to hit what I consider to be those most impactful to you, and really just talk through how you might want to begin to prepare your organizations for some of the changes that we're seeing. As we get into some of the actual language, we'll see that there's still a lot left to come. There's still a lot of detail left to come that will help us, but I think we can see which direction this deal is going. So as we get into no surprise no surprise billing, I really thought it might be useful to talk a little bit about the history and how we just ended up, where we are today. And ultimately, what we've seen over the last, decade or more are some of those services that are provided within the walls of a hospital, particularly provider services, things like emergency care, anesthesia, hospital services. Emergency actually leads the pack in surprise billing. But we've seen some of those services that have been outsourced undergo consolidation, largely by private equity groups. And for whatever reason, we've seen those organizations elect to be out of network or not part. We're not here today to talk about whether that's right or wrong, but the fact is that many patients have walked into, and matter of fact, this article says 61% of Americans have walked into an entity they believe to be participating with their plan and received a surprise medical bill. That ultimately got a lot of publicity, led to what I'll call a groundswell of support that spilled onto both sides of the aisle, and here we are with some regulation around it. So the act really, and at its core, is attempting to protect those instances of surprise out-of-network instances. And what's interesting, as we see a lot of these acts, really just picks on providers. The medical coverage providers or the health plans, they didn't get off the hook here. So the act kind of jumps right in on section 102, stating that health plans are required to hold patients harmless for surprise medical bills, and only to hold them accountable for their in-network cost-sharing, co-pays, deductibles. Now, underlined and highlighted what I believe to be the caveat here is for those services or procedures that are provided at an out-of-network services or out-of-network providers at an in-network facility. So the way I read this is that if you are an out-of-network facility, this does not apply to you. And that's my interpretation of that particular portion today. But it also states that in section 104 that as a provider, we can't hold a patient or we need to only bill patients for what we would consider to be the in-network cost share or their in-network amount, unless in the next two bullet points, the caveat here, we've obtained a consent within 72 hours and notify the patient that it's an out-of-network service. And there may be some obvious services that patients may seek that are out-of-network, and we can obtain the necessary consent for that. So for a second, let's play this out. Pretending that a patient arrives at our facility, our physician's office, what have you, and patient falls through the cracks, and for whatever reason we miss the fact that they're not in network. We send the payer a claim. That payer adjudicates that claim as out of network, sends us hopefully an adjudicated bill that lets us know what that in network median cost share, or what that cost share for that patient would be in network, and we can then bill the patient for the appropriate amount. But there may be, depending on the level of service and depending on the care that was provided, there may be instances where we as the provider want to seek some payment for those services. Enter section 103. Section 103 provides that 30-day open negotiation period for providers and payers, or providers to approach payers for some settlement of these out-of-network claims that are bound to happen, especially in what I would guess to be our physician practices, and seek some level of payment. The way that this will work is if we can't reach a settlement, we can enter a binding independent dispute resolution process. Really how this is going to work is both sides submit a bid, and the arbitrator is going to pick one, and the loser pays for arbitration. It'd be, I think, a pretty simple process. Big question mark here is, which way is IDR going to lean? Are they going to lean more on the side of, the provider? Is this going to help us for those providers that maybe aren't necessarily credentialed as in network yet? Don't know. There's more to come on that, but certainly the effort here is to get providers and payers to the table to settle. We see the last bullet point here that if you've entered arbitration, you can't go back to the well for the same entity or the same payer and around the same service for 90 days. So the goal here is to get people to settle these claims. So how do we prepare? Well, first of all, 30 days is not a very long time to recognize this claim as out of network and get that to the appropriate personnel within our organizations. Reach out to the payer to say, hey, we'd like to talk to you about a payment for this service, and then be prepared with some kind of settlement offer. Well, the one thing that I've seen in this language in this act over and over again is the terminology median rate. So my recommendation at this point is to understand your median rates, and many of us recently went through a pretty extensive pricing exercise whereby we had to kind of list out all of our rates. Well, we could get to the median or pretty closely, and it would be very defendable if we applied volumes or weights to these already established rates that we have out there, and we could get to a median for CPT codes fairly quickly in that manner. So again, moving quickly, shuttling those claims to the right individuals, having that individual with some authority to some dollar threshold, being able to discern whether or not we want to go after a settlement, being prepared with those median rates and getting in contact with the payer, I think is going to be, at least what we see right today, the way that this is going to work. So next couple sections here, 111 and 112. In my estimation, this is the most groundbreaking, biggest deal in the Act, quite frankly. And this is an attempt in the Act to get upstream of surprises by notifying patients before services even occur. And again, Section 111 says to the payer, hey, you've got to provide patients with an advanced explanation of benefits 3 days before a service. Well, that opens up a lot of questions. Who's going to notify the payer of these services? What if the service is urgent, needs to be provided within 3 days? So there's a lot of questions around that. And on the flip side, for providers, says that within 3 days of an advance or 1 day after scheduling, we are required to provide patients, at least for these, I'm assuming, scheduled services, a good faith estimate and what the coverage looks like for that procedure. Quite frankly, that's just a real heavy lift for a lot of the organizations that we work with. Many organizations that we work with today don't have even a price estimator and don't have the staffing capability to do this. So without some level of cooperation from our payers and some level of automation that would work much in the way of eligibility, this becomes very difficult for many of our smaller organizations. So I think a lot more to come on this particular section because there's some questions out there. Again, how to prepare. I think what we're seeing is a lot more emphasis on transparency, a lot more emphasis on understanding our prices within our organizations and getting some level of good faith estimate to our patients. We know that this the way that this is written today isn't the way that it will be in 2022, but it's pointing us towards those elements of financial clearance and those elements of estimation and tightening up those processes at the front end of our revenue cycle. So that's my recommendation today, is to look within your organization and do that high-level gap assessment or gap analysis around, how are we, where are we strong, where are we weak in those areas of financial clearance. And so we've outlined those areas that we consider financial clearance and that will be applicable in this sense. And those things are insurance verification. What percentage of the time are we getting verified insurance, and is it 80, 90% of the time? How much or how well are we doing there? And then those areas of certification, prior authorization, hopefully will serve as a notification to the payers. But tightening up that, and then ultimately getting not only getting an estimate, but checking the accuracy of those estimates will be important going forward. So as we wrap it up, certainly, not an effort to be the bearer of bad news, but ultimately trying to do what we can to prepare you to continue to maximize payment for the services you provide your patients. So with that, I'll turn it back over to Chris, I think, and Mr. Love for questions.
Thank you very much. And if you have a question, make sure you put it in the question box. But we do have some questions, and I'll kind of categorize these. This is a 340B question. Are covered entities submitting claims data to 340B ESP?
Yeah, and I'll definitely spend a little bit of time answering that. And the short answer is no. So really, when we work with covered entities across the country, and what we're seeing as far as some of the studies on submission of data to the 340B ESP based on those requests from the manufacturers, entities aren't submitting data. And a lot of this is based on, this decision's based on what their legal has told them, what advocacy groups has told them, and really just doing their part to kind of join in the fight as far as not submitting data to kind of keep all of these lawsuits and kind of keep this push moving forward.
Thanks. The second question I have relates to, I guess, under the RAC. Of the folks that you're working with, if you're looking at some of the RAC or even other audit activity, what are you seeing is kind of the primary focus of what's coming out of those audits?
Thanks, Steve. This is Paula. And yes, I think probably what we're seeing the most is working with some hospitals up in the HMS region and really seeing the MSDRG validation audits and also the APR-DRG with Medicaid, and then the short stay. And again, we kind of think that if there's an MSDRG request for coding, then while the RACs and other auditors will do the same thing, when they're in there, they'll identify other things that they want to deny. So I would say, yes, the short stays right now. And again, it can be really surprising because we're seeing 3 to 4 day stays that are being denied as not medically necessary. Thanks, Steve.
Thank you. Yeah. You know, you may have covered this, but I want to make sure, when do you think we'll get additional detail, language, and information regarding the No Surprises Act?
Yeah. HHS come out and said that they're expecting to have further details and language in July. So just in a couple of months, we should have a lot more substance in terms of, you know, what would be at least out there for comment in July. And I think it'll be interesting to see on some of these sections, like I said, especially section 112.
Right. So July, yeah, you're right, in a couple of months. So hopefully we'll get some additional information and clarification. And I'll kind of throw this question out. What are you seeing as to how organizations are working to improve their DISH percentage?
Sure, and I think that's been the focus of a lot of organizations, and really what we're seeing, you know, obviously DISH scrubs, and I think organizations around the country have been doing those DISH scrubs for a long time. Psych unit decertifications, so decertifying our psych units to expand Medicaid inpatient days, and then really looking at the DISH percentage on a monthly basis. And this will really allow you to have a strategy in place to convert to potentially either a sole community hospital or rural referral center if you meet those requirements in order to participate at a lower DISH percentage. So those are really the 3 things that I'm seeing most entities do.
Great. And Paula, let me ask you this, you know, not just RAC audits, but you put up some good data related to the OIG and their focus. To the people that are listening to this, what would you offer as advice as to how they should prepare for future audits?
Yes, thank you. I really think, you know, just being aware, I think that we kind of got a little complacent with RAC audits, and just be aware of what is going on. You know, just because Cotivity is not HMS, they tend to follow each other with their audit activities. So if HMS is having success in its region, it will trickle down typically to other RACs, not just Cotivity, but other RACs in other regions. So yes, a lot of data mining and just the compliance office to be very aware, and maybe to join some RAC listservs, and most definitely Cotivity, but just watch the others too, because typically they'll start following each other with their activities.
You know, that's good advice, and you're right. You know, I've been in healthcare 45 years, and you're exactly right how you have to watch and see how it trickles to others. You know, COVID-19's been here for 14 months, and it's been tough on everyone. One of the silver linings if there is one, is probably the focus on virtual visits and dealing with telehealth and telemedicine. So let's take that same rationale and apply it to no surprises. Is there any positive or good circumstances where the No Surprises Act could be beneficial to providers, in your opinion?
Good question. Glass is half full. So, what I would say is there's a couple of scenarios that I've certainly been trying to think through, and I know for hospitals that employ physicians, and most do, we have common scenarios where we have a provider that starts before the payer has executed the agreement, or sometimes they won't backdate the agreement, and we end up holding claims or struggling to get paid for certain claims. Does this mean that we can bundle those claims and approach an arbitrator and an arbiter and ask them to help us settle these claims? I mean, that's on the face of this kind of what it says, that it's out of network and we're trying to get in the plans, extending the application process. So that's a scenario that could help organizations, or maybe it gets those plans to expedite the process. And probably one other that I've thought through is, if we're going to go out and we're going to get an authorization for a service, and the payer then has to let the patient know if it's approved or not approved and provide that cost share information, does that mean that there's going to be a reduction in those denials? Or denials going to go down because the payer's already said it's approved? They can't play that game where they come back and say inappropriate place of service or med necessity. They've already told the patient it was covered. So that, maybe that could be beneficial. I think there's maybe a couple of scenarios where some things could be, a lift for providers.
Chris has been checking the chat box and the question box, and I think at this point we've answered all the questions that were pending. So Dan and Paula and Brian, terrific job. We really appreciate it. Do you have any final thoughts or words before we close?
I do not. Just appreciate the opportunity very, very much. And again, please do not hesitate to reach out directly. Emails are listed here with any questions you may have. We're happy to help.
Well, thank y'all. Great job. And I know people always ask, and we've had a couple of questions related to the slides. And with y'all's permission, Chris always, after the webinar, either later today or tomorrow, will distribute the slides to the people that participated and even people that registered but maybe for whatever the reason missed the event. So on behalf of the DFW Hospital Council, I want to thank BKD for this very informative and educational webinar. Thank you very much.
Thank you. Have a great day.